Alright folks, let's talk about the money pit that is chronic low back pain. It's the West's favorite musculoskeletal issue, costing billions, fueling misinformation, and making us terrified of bending over to pick up a sock. But fear not, today we're cutting through the nonsense with science. We're diving into the best evidence on chronic low back pain rehab. Things that don't work: TENS, ultrasound, kinesiotape, massage, osteopathy. Basically, if it involves a gadget that goes bzzz or a practitioner whispering your spine is out of fucking alignment, it's probably nocebo at best. What actually helps? First of all, establish bonds with the patient. Use empathic, active listening. Not a special, magical kind, just listen to what the other person is saying. And when I say listen, I mean shut the fucking mouth and open the ears. Attentively validate what the patient is saying in a non-judgmental environment. Use non-verbal, violent communication to understand the needs and requests for help of the person in front of you. And I know you want to provide education, to inform them about what's really going on. The Western health system is a mess. We're ending up in a fucking pandemic of misinformation. Saying so many misconceptions about our backs, how they're fragile and all that bullshit. But hold your horses, man. You need to ensure the patient's self-efficacy. He or she needs to reach that confidence, to take control of their own health. And before they even talk to the doctors, you need to explain many things to them. Make sure, really make sure, that the patient is open to listening and that there is a strong clinical alliance between you. Otherwise, you're just showing off, filling up your doctor ego. If in front of you you have a catastrophizer, neuroscience education helps. But first, you have to target the pain behavior using strategies that increase the locus of control in the person in front of you. Basically, understanding the patient's burden. And I know that, at first impression, it will sound a bit cuckoo what the patient is saying, but we let go of the judgments and bring in empathy and compassion. Once all this has been established, you can promote the optimistic movement approach. In vivo exposure means that you ask the patient to perform the most painful activity they can experience with. CLBP patient, it is often bending, pause, my friend. So, let them bend unconsciously by dropping a pen and asking them to pick it up. And ask them what their will is if magically, the pain will disappear. You can use visualization. Let them imagine performing the so-missed activities. Let them relax, maybe with some guidance. Help them let go of the muscle guarding in their core, the so-named bracing. And remember, pain is a multifactorial response. Don't address it like something to fix because you can't. You can help the patient break down their disability. Helping people instead of draining their wallets. Do not focus too much on pain in this kind of patient. That's not the key. So, let them move, and not because of that, have a weak back. Because you want to break the fucking misbelief of a weak back. And apply the best evidence. So, you can also include manual therapy, and of course, education when you see it is welcomed. If you liked this video, subscribe, hit the bell, and if you're a physio still recommending electrotherapy for CLBP, please reconsider your job. Choices. Sources: Malfliet et al. Best Evidence Rehabilitation for Chronic Pain, Low Back Pain, O'Sullivan et al. Cognitive Functional Therapy, and Integrated Behavioral Approach for CLBP, Wood et al. Pain Neuroscience Education plus Exercise Meta-Analysis.